Hello everyone, welcome to Test and Explanation Super Specialty Pediatrics Part 4. Here I shall be taking up GIT and hepatology, few topics from respiratory system and a few questions from CVS as well. So let us start with the discussion. As is the norm, first of all, we need to focus on the topics which are important and which have been asked frequently in the previous super specialty exams. These are the topics you are supposed to go through in the last 2 or 3 weeks when you are doing revision. So when it comes to GIT and hepatology, topics like celiac disease. Celiac disease is one of the favorite of not only NEET SS examiner but also INI super specialty examiners. Acute diarrhea causes are very frequently asked. IMNCI assessment of dehydration. This topic has not been asked in the last 2 years, but this topic never goes out of fashion. IMNCI assessment is like Mahendra Singh Dhoni in 5PL. Thala and never goes out of IPL, never retires and can hit sixes whenever the opportunity arises, right? Then what I basically mean is you cannot go into the exam with loosely doing the topic of IMNCI assessment of dehydration. Then intestinal atresia has become important. If you look at the trend, last 2 to 3 years, questions have been asked on duodenal atresia, they have been asked on jejuno-ileal atresia, and intersusception again is the topic on which questions are asked. So atresias, obstructions in children, their DDs, their presentation, they are important. Hirschsprung disease is important. Inherited hyperbilirubinemias are important. Crigler-Najjar 1, Crigler-Najjar 2, Gilbert, Reuter, Dubin-Johnson, they are important. Alagille syndrome has made a hat trick. It has been asked at least 3 times in the last 3 exams. Once it has been asked in INI SS, twice it has been asked in NEET SS exam. So you can get a fresh question again on this topic. Chronic HBV and HCV are important, not only the diagnostic part, but also the treatment part. And acute liver failure is one of the perennial favorites of NEET examiner. And finally, portal hypertension is also important. So these are the topics in GI and hepatology. Moving to pulmonology, you have topics like pneumonias, topics like cystic fibrosis, Lemire syndrome. Lemire syndrome has been asked twice in the recent NEET super specialty exam. Acute otitis media, congenital pulmonary malformation, and croup versus acute epiglottitis. Moving to CVS, for unknown reason, the last NEET SS exam had significant questions asked from CVS, and there was also 2 questions, one direct, one indirect, asked on cardiac looping, which is an embryological process. Because it's a tough topic and I don't think it has been discussed properly in any of the system, taking it in our super specialty exam discussion will not be appropriate. Reason being, it is a topic which requires at least 10 to 15 minutes of focused, dedicated reading and understanding. Keeping that in mind, a small update on this has already been recorded by myself, and by the time you are seeing this video, that update should be shortly available. And so if you are sitting in the NEET Super Specialty Exam 2025, make sure that you go through that 5-10 minute summary of cardiac embryology. That is very important. Apart from that, the other embryological questions, including 2 previous year questions, I have included in this discussion. So embryology is important. It is often the rank decider also. Syndromes and congenital heart disease, there will always be worst case scenario, 1 question asked on 1 syndrome and the common congenital heart disease. 5 common CHDs, ASD, VSD, PDA, TOF, coarctation you have to do. Apart from that, HLHS, TGA, TAPVC are important. Infective endocarditis, there is always 1 question asked. ARF prophylaxis is important. The duration table which is given by EHA, that is important. Myocarditis, treatment of arrhythmias is important. CCF drugs are important. And AS and HOCM have been asked in both NEET SS 2023 and NEET SS 2024. Whether it gets asked in 2025, you people will be telling me. Cardiovascular system and hepatology are the kind of rank deciders when it comes to super specialty. Why? Because sometimes atypical, tough questions are asked, and if you have a sound preparation in these 2 areas, just like Mahendra Singh Dhoni, you can hit the ball out of the park. Why am I giving examples of Mahendra Singh Dhoni again and again? Number 1, I'm a cricket fan. Number 2, I'm a fan of Dhoni as well. Number 3, topics like CVS and hepatology, we have a tendency to ignore certain times, or we have a tendency to read only what is asked. In these areas, newer questions are being asked, and you need to look at what are the current patterns. The current patterns say that apart from the usual topics like ASD, VSD, PDA, you have more questions getting asked on cardiac embryology, fine details being asked on cardiomyopathies, myocarditis, and sometimes in pericardial diseases also. When I have a look at the watch hours of super specialty videos at PrepLadder SS, I notice that most of you are not reading these areas properly. Trust me, it takes just 1 or 2 questions to get a dream seat. What others are doing, you are also doing. 2 or 3 such questions go right, you get your dream seat. So keep that at the back of your mind. Don't miss out on these areas, particularly embryology of cardiovascular system, treatment of arrhythmias, syndromes and CHDs, and these inherited hyperbilirubinemias along with Alagille syndrome. They are being very, very frequently asked, and every time more details are asked in the exam. I've taken quite some time explaining so that you have an idea what are the areas I'm going to focus. With that in mind, let us start with the discussion. Question number 1, it's an easy one. Question number 1 says NEET SS 2024, which of the following can cause pseudoappendicitis? So some organism which mimics appendicitis. So pseudoappendicitis is a differential diagnosis of acute diarrheal illness, and these patients can have right lower quadrant pain similar to appendicitis. It is typically produced by Yersinia enterocolitica. It's a one-liner question. It's a simple question. It is mentioned in Nelson also. If you have read Nelson, you must have gone through this paragraph. Nelson says that pseudoappendicitis secondary to mesenteric lymphadenitis, that is lymph node enlargement, is a notable complication of Yersinia, sometimes Campylobacter and COVID-19. Now, one school of thought says that, sir, when the question was asked in NEET SS 24, we got confused because Yersinia, Campylobacter, both were given. If both were given, still your answer will be Yersinia. Why? Because Yersinia, originally the term pseudoappendicitis was described for Yersinia. Can it occur in other conditions? If Yersinia is not in the option, you can mark Campylobacter, and sometimes COVID-19 also can be a possibility. And these are older children and adolescents which are affected. They present with fever, abdominal pain, tenderness localized to right lower quadrant pain, with or without diarrhea, and then that can be confused with appendicitis. Whenever you are in doubt, do ultrasound, and if ultrasound is not available, you need to go for CT or MRI. So answer to question number 1 is C, Yersinia enterocolitica. Remember these 3 points. Yersinia, second best answer Campylobacter, third best answer COVID-19, because examiner sometimes repeats questions and removes the answer which was previously there. Moving to question number 2. This question is similar to INI SS 2022. So it's not a NEET SS, it's a INI SS MCQ. And I'm quite happy to say that similar flow chart based upon this has already been discussed by myself in the rapid revision and also in the detailed videos. So look at the question. A 3-year-old child with failure to thrive, anemia, and steatorrhea is evaluated for celiac disease. His serum IgA-TTG is elevated, so it means there is a positive screening test. And how much it is elevated? More than 10 times the upper normal limit. So significant elevation is there. But his EMA is negative. What is true regarding this child? Let's look at the options. Let's apply some common sense and logic also. IgA-TTG elevation is sufficient for diagnosis of celiac disease. No, dear, it is not sufficient. If it was sufficient, why would we do EMA? Why would we do endoscopy and biopsy? IgA-TTG is only a screening test. It is not a diagnostic test. So it is not sufficient for diagnosis by itself. First thing. Second, EMA negativity indicates diagnosis is not celiac disease. No. Many patients can have EMA negativity as well. If histological evidence is there, you will still diagnose this patient as celiac disease. So B also is not true. Repeat EMA testing after 6 months. If today EMA is negative, what will happen after 6 months? Are we making any change in the diet? Are we giving more gluten or less gluten in the patient? No. The repeat testing has very limited application in such patient. That is not the diagnosis. So if one screening test is positive, but another one is negative, don't you think you should go for the investigation of choice, the gold standard, that is histopathological diagnosis? So child needs endoscopy and biopsy for final diagnosis. This is the correct answer. Logic also tells you this is correct. If you sit sometimes in your celiac clinics, then also you know that this is how we approach. And if you have gone through the flowchart that I discussed with all of you in the rapid revision part, then also you would know the answer is D only. Let us quickly revise that flowchart. This was the flowchart which I discussed with all of you. It is SFIGAN diagnostic criteria for celiac disease. It says any child coming to you with sign and symptom of celiac disease, you will do the first screening test, combination of total IgA. Why total IgA? Because you need to rule out selective IgA deficiency also, and IgA TTG. TTG is also written as TG2. So two possibility, either the test is positive or test is negative. If TTG is negative and there is normal total IgA, patient is not having celiac disease. If TTG is negative and total IgA is also less, it means it could be selective IgA deficiency. You will refer the child for pediatric GA consultation and also take a rheumat consultation alongside. If TTG is positive, then if it is equal to or more than 10 times normal, you will do EMA testing. If EMA also comes positive, you don't need to do biopsy. This is celiac disease, start gluten-free diet. But if EMA is negative, like in this child, you will do endoscopy and biopsy. Also, if TTG is positive, but it is less than 10 times the normal, then also you need to do upper GI endoscopy and biopsy. If biopsy shows histological changes, but they are corresponding to MARSH 0, that is a normal mucosa, or mild changes, mild subtotal villus atrophy is there, then you will say unclear or potential CD is the diagnosis. You need to follow up and monitor the patient. If it is MARSH 2 and 3 or above, then it is celiac disease and start the patient on gluten-free diet. This is the diagnostic algorithm for SFIGAN criteria. This question was asked directly from there. So by looking at this flowchart, you can easily say the patient needs to undergo endoscopy and biopsy. So what is the answer to this question? His TTGA is elevated, but anti-EMA is negative. So do endoscopy and biopsy for final diagnosis. Question number 3. This is similar to NEET SS 2024. Two versions I got. One version said, sir, photo was given. One version said, photo was not given. Photo given or not given, looking at the photo, you can know what is the diagnosis, right? Or 8-month-old child presented with severe abdominal pain, vomiting. Stools are as shown in the picture. This appearance is what you call as red currant jelly stools. So there is bleeding per rectum and the stools are having fresh blood along with necrotic debris and fecal material mixed with them. It looks similar to mixed fruit jam. It's not the jam that you have, the Kisan jam and all. All those, good quality imported jams. If you take them out in a container, their appearance will look something like this, red currant jelly stools. Once I was teaching in a class and the student said, sir, this is not looking like red currant jelly. This is looking like the roadside Manchurian I had last evening. I said, whatever makes you remember, but Manchurian word has not been mentioned in the textbook, so we cannot remember that. But the next time you have mixed fruit jam or you have Chinese Manchurian, the Indian Chinese Manchurian that you find, Chinese people don't eat that, by the way. So always think of the diagnosis as likely intussusception. Also, there is abdominal tenderness significantly present. Now, abdominal tenderness can be a feature of intussusception by itself also, and many times it can indicate some peritonitis as well. So what is the diagnosis? You are suspecting intussusception. And in intussusception, the initial investigation of choice is always ultrasound abdomen. If they say confirmatory test, then it will be enema, but we don't do barium enema because barium is contraindicated, particularly if significant tenderness is present. You will do a water-soluble contrast enema, and so the answer to this question is D. What does Nelson say? Nelson 22nd edition says, when the clinical history and physical findings suggest intussusception, an abdominal ultrasound is typically performed. Let's do a quick review of intussusception. A slightly longer review I have done in the rapid revision. You can go through that. Some selected points I will summarize here. When would you suspect intussusception in a case scenario or in your clinical practice? Examiner will give you a case scenario. There will be a child between 6 months to 3 years of age. There will be sudden onset colicky abdominal pain, lethargy, irritability and vomiting. There 60%, not all, but 60% will have bleeding per rectum producing the red currant jelly stools. There will be a tender sausage-shaped abdominal mass in the right upper quadrant with its long axis cephalocaudal. What it means is, if this is the upper quadrant, and this is the umbilicus, there will be a sausage-shaped mass present something like this in the right upper quadrant, right? And if it occurs in epigastrium, then it will be transverse. And hollowness will be present in the right iliac fossa. So there will be hollowness present here. That is called as dance sign. And triad of pain, vomiting, abdominal mass has a positive predictive value according to Nelson of more than 90%. If rectal bleeding per rectum is also there, The positive predictive value of having intussusception is approximately 100%. What about investigation? Investigation is ultrasound, but always remember that whenever there is tenderness, guarding rigidity, you need to rule out peritonitis or perforation. Now, investigation of choice initially is ultrasound abdomen. It has sensitivity of 90 to 100% and specificity of 98%. What is the sign shown? Look at this sign. This is what you call as target sign or donut sign will be seen on ultrasound. It will be seen on transverse view. When you do longitudinal view, then you will find a tubular mass. Confirmatory test will be contrast enema. What is the treatment? Earlier, we used to surgically treat, but surgeons are not very happy these days because intussusception, more and more cases are being non-surgically managed. Can intussusception show spontaneous resolution? Yes. Nelson says spontaneous reduction occurs in 4 to 10% of the patients. One of my colleagues, he is a faculty in one of the clinical branches in one of a separate platform. Taking name will not be appropriate. He actually told me this just a few months back. He called me late in the evening and said, "Sir, my child is having these symptoms. It is looking like intussusception." I said, "Sir, it looks like intussusception." He was in Delhi, so I said, "Please take the child to the nearest, either a pediatrician or better a surgeon." So he said, "Okay, I'm taking him." And then he called me 1 hour later saying, "It has spontaneously reduced." So what should I do? I said, "Sir, go with get a pediatric GI consultation and also get a surgery consultation, because if there is a persistent lead point, recurrences can happen." So that was, again, I have read it, but I have seen just, about 4 or 5 months back that it did happen with one of my colleagues' son as well. So spontaneous reduction, according to Nelson, also occurs in 4 to 10% of the patients. First line therapy is enema. You will do air or hydrostatic enema. It has a 80 to 95% success rate in ileocolic variety of intussusception, which is the common form. When would you do surgery? Indications for doing surgery. Potential MCQ point for future exam. If there is intussusception with refractory shock, do surgery. If there is bowel necrosis, do surgery. Perforation, do surgery. Peritonitis, do surgery. Multiple recurrences or multiple lead points present, do surgery. Failure of enema, do surgery. Okay, and it is generally laparotomy which is preferred. Question number 4. This is NEET SS 2023 question. Which of the following subtypes of jejunoileal atresia has apple peel appearance? As I said, if you see it up till 2022, the examiner was fond of asking duodenal atresia and CHPS. But the shift happened 23-24. There were questions asked on jejunoileal atresia. So if I am a student preparing for these exams, I would always read in the last week intussusception, duodenal atresia, jejunal atresia, CHPS. Very good probability. Worst case scenario, you will get at least one question. So let us do a quick review of this. They're asking the classification of jejunoileal atresia. Now we have small intestine. It has 3 parts: duodenum, jejunum, and ileum. Jejunum and ileum atresia are considered together, so it is also called as jejunoileal atresia. There is a classification for that which is given in Nelson also. Nobody reads, but you are supposed to read now for the exams. So what does the classification say? It says that intestinal atresias of jejunum and ileum are divided into multiple subtypes, starting from type 1 till type 4, and type 3 is having 2 subvarieties, 3A and 3B. How to identify? Look at this picture. It says this is the intestine. Okay, this is the intestine which is patent. This intestine is also patent. The intestine is otherwise normal, mesentery is normal, blood supply is normal. Why the lumen of the distal intestine is small? Because there is a small membranous narrowing obstruction which is happening here in the intestine. So this is called as type 1 variety. What is type 1 variety? In type 1, there will be mucosal obstruction. There will be mucosal obstruction of the lumen, but the bowel wall and mesentery are intact. Bowel wall and mesentery are intact. This is called as type 1. So basically what happens is, this was the intestine coming, then there was this obstruction happened. This obstruction is membranous obstruction in the lumen, and then you have the remaining bowel which becomes something like this. It is now smaller in size, but the blood supply is otherwise normal. This is called as type 1 variety. What is type 2 variety? Type 2 will have 2 blind ends. This is one blind end. This is one blind end, and this is another blind end. Can you see? This is one end, this is one end, and there is No, there is only a fibrous cord present in between. So what is type 2 variety? There are two blind ends. There are two blind ends, two blind tubes separated by a fibrous cord. That is called as type 2 variety. Then we have type 3 variety. In type 3 variety, you will have a V-shaped mesenteric defect. There are blind ends with V-shaped mesenteric defect. Can you see this V-shaped mesenteric defect which is forming? This is called as V-shaped mesenteric defect. V-shaped mesenteric defect. Type 4 is the form in which there will be this appearance getting produced. The apple peel appearance of the intestinal atresia will be there. So type 3B variety, this is type 3A, and type 3B variety will be having the so-called apple peel. If you try to peel an apple using that peeler, thick skin which comes out is having an appearance something like this. So this apple peel appearance is seen in type 3B. And finally, when multiple atresias are present, that is called as type 4. What is type 4? Multiple atresias. Multiple atresias. It is not very complicated, just keyword you have to hold. So which of the following subtype has apple peel appearance? It's a one-liner question. It is type 3B which has apple peel appearance. Let us do a quick review of the topic of jejunal-ileal atresia. First of all, when would be the clinical suspicion be there? Suppose you get a case scenario. How would you know? Examiner will say newborn presenting with delayed meconium passage, bilious vomiting, abdominal distension with antenatal history of polyhydramnios. Now it should come to your mind, sir, why it is not duodenal atresia? In duodenal atresia, there is all these features, but abdominal distension is not there. Why it is not CHPS? Number one, CHPS will not present in the first week. Secondly, CHPS will have a non-bilious vomiting. So remember, CHPS will have non-bilious vomiting, so cannot be the answer. Duodenal atresia, similar presentation can be there, but no abdominal distension is seen in duodenal atresia. And so you can easily rule them out. So I will summarize again. If the examiner says, child beyond 2 weeks, non-bilious vomiting, projectile vomiting, no abdominal distension, CHPS, also called as IHPS, pylorexinosis. If the examiner says newborn in first week of life, delayed meconium passage, bilious vomiting without abdominal distension, double bubble appearance will be there, duodenal atresia. An examiner says delayed meconium passage, bilious vomiting, abdominal distension present in the first week of life, and triple bubble appearance or multiple air fluid levels shown, your answer will be jejunal atresia. So catch the keyword and reach the correct answer. An examiner just sometimes checks whether you know these keywords, these buzzwords or not. Now, X-ray, what will show X-ray show in jejunal atresia? It will show triple bubble appearance in jejunal atresia. It will show multiple air fluid levels in ileal atresia. However, Nelson also says that some patients have only haziness in the right lower quadrant, particularly if there is meconium ileus present. And water-soluble contrast enemas are needed for eventual diagnosis. Ultrasound is plus minus for diagnosis. And most patients require surgery, so open surgery, that is laparotomy, will be needed. Question number 5. A 3-week child presents with persistent projectile vomiting after each feed. Small mass is palpable in the epigastrium region and peristaltic waves are detectable. Visible peristalsis indicates obstruction. And surgical consultation was requested. IV fluids are instituted. Patient is prepared for surgical intervention. What is a recognized risk for this child? So 3-week child, projectile vomiting. If they don't mention bilious, we assume it is non-bilious. And a mass palpable in the epigastric region with visible peristalsis. This is fitting into CHPS or IHPS. Which of the following is a risk factor? Is a male gender a risk factor? Yes. Trisomy 21? No. DPT vaccination? No. Topical erythromycin? Systemic erythromycin is there. Topical is not. So answer to this question is A, that is male gender. It looks easy, but it is, your mind should be able to make the diagnosis also in the exam. So what are the risk factors for CHPS? It's often asked. The cause for CHPS is unknown, and that is why we call it as idiopathic. That is why it is called as idiopathic. But there are certain risk factors. The risk factors include, first of all, male child. Second is firstborn child. So first child in birth order has higher risk. Third, if there is a positive family history, the risk is more. Fourth, if the patient is having blood groups P and O, the risk is more. Fifth, it is associated with erythromycin use. Erythromycin use is systemic. Systemic means either oral or parenteral. Baby receiving erythromycin is also a risk factor. Mother receiving who is lactating is also a risk factor, because erythromycin can be transferred via milk also, small amounts. Not in normal child, but a predisposed child will have chances of obstruction happening. The circular smooth muscle hypertrophy will be more prominent if erythromycin exposure occurs in predisposed individual. And then we have certain syndromes. So syndromes associated with them include Edwards syndrome, trisomy 18, Apert syndrome. It's a syndrome associated with craniosynostosis. You remember? Bilateral mitten hand, bilateral syndactyly, that syndrome. Zellweger syndrome. It's a peroxisomal defect, peroxisome biogenesis defect. It is associated with Cornelia de Lange syndrome. And it is associated with Smith-Lemli-Opitz syndrome. These are the important syndromes which are associated with producing CHPS. Right. Also remember that rotavirus vaccination is a risk factor for intersusception, but it has no role with CHPS, and DPT vaccine does not cause any GI problem per se. Question number 6. This is NEET SS 2023. In fact, similar question has been asked in older NEET SS exam also. Infant is being evaluated for jaundice. He has cholestasis. So cholestatic jaundice is there. Triangular face, deep set eyes, pointed chin and bulbous nose. Facial dysmorphism with a triangular face. Pulmonary artery stenosis on echocardiography, what is the likely diagnosis? So neonatal cholestasis, pulmonary artery stenosis and facial dysmorphism with a triangular face, everything fitting into JAG1 gene or Notch2 gene mutation associated syndrome, that is Ehlers-Danlos syndrome is your answer. We have discussed this in details. It is there in the detailed video. To save my time, to save your time, please go through the detailed video. There is a dedicated video I have put on this in the detailed videos. But key points we will summarize here. Look at this. I have already discussed. You can ignore this person who's sitting here. So liver and biliary tract, the hallmark in these patients is bile duct paucity. There is absence or reduction in the number of interlobular bile duct in portal triad. And so they present with neonatal conjugated hyperbilirubinemia. Some patients can have present onset of jaundice later as well. And intractable pruritus with cholestasis is present. Second, they have dysmorphic faces. Look at this face. There is a triangular face, pointed chin, angle of mouth is drooping, and they have frontal bossing with a prominent bulbous tip of the nose. Apart from that, these patients can have pulmonary artery stenosis, pulmonary valvular stenosis, and other heart diseases. Already I have put a question here. Can you see? This is a repeat question. So this is a repeat topic. It is getting asked again and again in the exam. Still, if you get it wrong, not acceptable. And axial skeletal vertebral defects like butterfly vertebra can be seen. Hemivertebrae and fusion of vertebrae can also be seen. And fifth involvement can be in the form of eye involvement. So a deformity known as posterior embryotoxon, that can also be seen in the patient. The most commonly it is associated with JAG1 gene mutation, and it is associated with the Notch2 gene mutation. These are the two genes which are mutated in a patient of Ehlers-Danlos syndrome. Right? Even they are previous year question. Moving to question number 7. A 7-year-old child is evaluated for hepatitis. He had one episode of hemolysis in the past and is having normal eye examination. Family history is positive for ATP7B gene mutation. What is the best diagnostic modality? So what is the information that we have? This child has liver involvement. This child has liver involvement. He has hemolysis. And he has ATP7B gene mutation. If all the three information you process, the child is likely suffering from Wilson disease. Now you might think, sir, Wilson disease will have Kasher-Fleischer ring, it should have cataract, it should have Parkinsonism. Remember that CNS and eye involvement occurs second decade of life onwards. This is a 7-year-old child. So in the first decade of life, liver involvement is predominant, and in the, somewhere around 7 to 10 year, occasional hemolysis can also be seen. But second decade onwards, you will have the other organ manifestations appearing. So what is the screening test for Wilson disease? Screening test in children is serum ceruloplasmin. In adult, we check for 24-hour urine copper. However, the best diagnostic test will always be liver biopsy, where you do quantitative hepatic copper estimation. Hepatic copper estimation, if you find more than 200 microgram of copper per gram hepatic tissue, that is diagnostic of Wilson's disease. And C is your correct answer. So, Wilson disease, what are the key points you should remember? Wilson disease, ATP7B gene mutation. Wilson disease, first decade of life, the patient is having hepatic involvement. Hepatic involvement can be in the form of acute liver failure or progressive chronic liver disease. Second decade onwards, hepatic involvement will be there, but the patient will also have CNS involvement and patient will have eye involvement, and both tend to occur together. CNS involvement occurs in the form of early onset Parkinsonism features. Dopamine producing neurons in the basal ganglia are destroyed. Eye involvement will be in the form of KF rings. Sometimes there can be sunflower cataract. Another interesting question I was seeing in the NEET PG exam, not super specialty, but there is no harm in discussing that. Two types of questions I have seen in recent NEET PG exams. One question said, which of the following is the most common ocular lesion in Wilson disease? The answer will be KF ring. But if they insert a word, which of the following is the most common lesion of eye producing vision loss? The answer will not be KF ring, because KF ring is on the periphery. It is in the Descemet's membrane of cornea and does not affect the central part. It is the sunflower cataract which will be your answer if they are talking about vision loss. So look at the question if a similar question or similar option gets asked in your exam. And apart from that, if you have to do screening, the screening in the patient should always be done according to age. For a child, you will do you will check for serum ceruloplasmin levels, which will be found to be low. Whereas in case of adult, you can go for 24-hour urine copper excretion, which will be increased. However, investigation of choice in both of them is same, liver biopsy. And quantitative hepatic copper estimation should be done. Moving to question number 8. It is similar to NEET SS 2024 MCQ. Now, question number 8 says, a child with persistent yellow discoloration of sclera since many months. So there is jaundice-like feature since many months is evaluated, found to have mild conjugated hyperbilirubinemia. LFTs are normal. Liver biopsy revealed a dark melanin-like pigment in the hepatocyte, especially in the central lobular region, likely deficiency of. First of all, we need to make the diagnosis. So this is a child with persistent conjugated hyperbilirubinemia, LFT normal, and melanin-like pigment. Melanin-like pigment, dark liver is a feature of Dubin-Johnson syndrome. Dubin-Johnson syndrome. Now look at these four options. Can alpha-1 antitrypsin deficiency present like this? No. It will have cholestasis. It will have pulmonary involvement. It will have emphysema-like changes as well. And it will not have mild hyperbilirubinemia. That is ruled out. OATP1B1 deficiency is associated with Rotor syndrome. Rotor syndrome will not have a melanin-like pigmentation. That is ruled out. UGT1A1 deficiency of this produces Crigler-Najjar 1, Crigler-Najjar 2 as well as Gilbert syndrome, but they all are unconjugated varieties. So this is also ruled out. What are we left with? MRP2 gene. MRP2 protein. MRP2 protein is produced by ABCC gene, and MRP2 is a bile canalicular transporter whose deficiency is responsible for producing Dubin-Johnson syndrome. Because the diagnosis is Dubin-Johnson syndrome, the answer to this question is B, MRP2 deficiency. In other words, the diagnosis is Dubin-Johnson syndrome. Now let us have a look at approach to inherited hyperbilirubinemias, how we are going to approach. Whenever you get a question on this, always look at what kind of hyperbilirubinemia is being talked about. First possibility, they are talking about unconjugated jaundice. Second type, they are talking about conjugated hyperbilirubinemia. Unconjugated variety, if they say neonatal presentation, severe, absent UGT1A1 activity, that is absent conjugating enzyme activity, the likely diagnosis in such a patient will be Crigler-Najjar type 1. They all will develop kernicterus and outcome is very poor. Second variety, if they say presentation in the newborn, it is moderate to severe, and the UGT1A1 activity UGT1 A1 activity is decreased. It is about 10% of the normal. Connectors may or may not occur. These patients are Kriegler-Nadler syndrome type 2. And these are the patients who will benefit by giving lifelong phenobarbital supplementation. Phenobarbital induces enzyme activity and it induces the conjugating enzyme activity also. And third variety will be newborn. Rarely they may have infancy or childhood onset, but neonatal presentation. Mild variety of unconjugated jaundice. UGT1A1 activity is between 10 to 35% or more. These are the patients who are having Gilbert syndrome. So there is a spectrum. On one end, you have a very severe disease, Kriegler-Nadler 1, and on the other hand, you have a mild disease which is compatible with life, and only during strenuous activity, stress, illness, the jaundice will appear or it will become significant. They will manifest in the newborn period. A few patients can manifest later as well. That is Gilbert syndrome. If they are talking about conjugated jaundice, remember that if they say there is dark liver, urinary coproporphyrinogen excretion is abnormal, along with dark liver, the likely diagnosis in the patient will be Dubin-Johnson syndrome. The liver is dark because of a melanin-like pigment which is derived from epinephrine metabolism. If they say a normal-looking liver, no pigment, the possibility will be Rotor syndrome. Eventually, you need to do urine coproporphyrinogen excretion pattern. In normal people, the absolute amount of urine coproporphyrinogen is low, and type 1 is less in you and me, and type 3 is more. In both Dubin-Johnson and Rotor, the type 1 variety is more. It is just that in Dubin-Johnson, it is more than 80 to 90%, whereas in Rotor syndrome, it is somewhere around 70 to 75%. So these tests, the details of these tests I have already discussed, so I will not go into the details. But this approach will make sure that your diagnosis kind question does not go wrong. Moving further, we have question number 9. Question asked in NEET SS 2022-2024 with minor changes. So question says, 6-year-old child presents with hepatomegaly, jaundice, deranged coagulogram and altered sensorium is diagnosed as acute liver failure. So 6-year-old child with acute liver failure, which investigation shall predict severity of the disease and also useful as daily marker of disease progression? Immediately you can rule out APTT will not be the answer. APTT gets prolonged at a much later stage. Serum, all the 4 things in fact can occur. Which one is the best answer? Remember, how do you make the diagnosis of acute liver failure? The duration should be less than 8 weeks and you're using PT and INR as the diagnostic criteria, prolongation. Plus, if you look at AIMS PICU protocol 2022, that also talks about PT and INR being important in the prognosis. This answer will not come from the tables that we have discussed in Nelson. The Nelson table talks about serum bilirubin and ammonia also. How do you get the answer? Look at these options. First of all, when you make a diagnosis of acute liver failure, if there is duration less than 8 weeks, no evidence of chronic liver disease, plus coagulopathy, PT more than 15 or INR more than 1.5 with encephalopathy, or PT more than 20 second, INR more than 2.0, irrespective of encephalopathy. This is how you make the diagnosis. So PT, INR, they are important for diagnosis. Also, if you have attended your clinics properly, you would know that PT and INR are frequently done to assess monitoring to predict prognosis in these patients. So what does AIMS protocol says? It says, look at this, the prothrombin time is a useful dynamic marker of liver function and should be monitored daily as it reflects accurately the state of liver function. Liver enzymes, AST, ALT, they are done, but they have poor correlation. Reducing level of these enzymes with the worsening INR reflect a severely depleted hepatocyte reserve rather than an improvement. So PT INR assessment is your best answer among the options given. If you go through review articles and if you have attended your hepatology clinics and managed a patient with liver failure, you would know PT INR is the answer. Serum bilirubin, it is elevated, but again, it is not a marker of disease activity. It is useful only in conjunction with the other parameters. Serum ammonia, again, it is not the only reason for encephalopathy, and serum ammonia levels, if they are high, they indicate a poor prognosis, but if they are low, then also you don't say that it is a mild acute liver failure, right? So they do not correlate well with the disease severity. So what is the best answer? PT INR assessment. You can remember as one-liner also. Most important marker for disease activity and the progression and overall prognosis, it is PT-INR assessment. In which disease? Acute liver failure. Question number 10. 6-year-old boy presented with acute onset emesis. So there is upper GI bleed. HbO 5.4, obviously he has bled a lot. Examination revealed splenomegaly. Isn't it portal hypertension with variceal bleed? Because there is massive bleed happening with splenomegaly is another clue. He was given fluid boluses for resuscitation. Okay. Initial management was started. All of the following are indicated prior to endoscopy during acute management except. Would you give pantoprazole? Yes, you would give. Would you give IV antibiotic cover? We have to do endoscopy. It is given. Erythromycin or other broad spectrum antibiotics can be used. Octreotide infusion is given or terlipressin infusion is given if variceal bleed is suspected. What about PRBC transfusion? PRBC transfusion is given, but the target hemoglobin is always between 7 to 9 gram per deciliter. We do not go above 10. If you make the hemoglobin above 10 by transfusion in any portal hypertension pressure, it will further increase the portal pressure and lead to worsening of the bleed or recurrence of the bleed. So what should not be done during acute management is this. Let's do it. The details of this I have already discussed in the detailed videos. Acute management of upper GI bleed: whenever a child comes to you, airway, breathing, circulation. Obtain IV access. If the child is having shock, many of these children will be in shock. So start Ringer lactate or normal saline boluses. These days normal saline is preferred, but you can use either of them. 10 ml per kg bolus will be, 20 ml per kg bolus will be given each. And how many boluses can be given? Up to 3 boluses can be given. And arrange ideally cross-matched, if not available, O negative or cross-matched blood transfusion. And which blood should be used? PRBC transfusion should be given. And when you are giving PRBC transfusion, the volume should be about 10 to 15 ml per kg over 30 to 60 minutes. If you find that you are giving too fast, then you can slow it down or you can add diuretic as well. And the target hemoglobin in such patients should always be between 7 to 9 gram per deciliter. Do not touch the value of 10 by transfusion. Then as a part of empirical therapy, in the first hour management, you will give IV pantoprazole and you will consider giving IV octreotide or IV terlipressin. These will be started, these will be given if you are suspecting a variceal bleed. If you are suspecting a variceal bleed. And you need to do endoscopy, and definite management should be started by endoscopy. Endoscopy should be done within 6 hours of hospital admission, although that is not always practical. Plus, you will give supportive therapy, and so you will give supportive therapy, and as a part of supportive therapy, you will start IV antibiotics also. You need to give IV antibiotic cover prior to doing endoscopy. At least one shot of IV antibiotic cover should be given in the patient. So if you go back to the question, you can easily understand that A is the thing that will not be done because they are asking except it will not be done. Don't raise the HB above 10 gram per deciliter. This question is based upon that funda. Now moving to question number 11. A 3-year-old child is having cough for 2 days, now brought to hospital with complaints of fever, worsening of cough and coryza. His heart rate is 100 per minute, obviously because there is fever, so there will be some tachycardia. Respiratory rate is 42 per minute, which is on the higher side. Do remember that age-wise respiratory rate are the cutoff for tachypnea in the child. Age less than 2 months, the cutoff is 60 per minute. 2 to 12 months, it is 50 per minute. And 1 to 5 year, 40 per minute. So this is a 3-year-old child, 1 to 5 year age, and respiratory rate 40 and above is considered tachypnea. So this is a child who's having tachypnea. So I will mention here the child is having tachypnea, right? So tachypnea is present in the child. Second, you see SpO2 is 95% on room air, which is within normal limits. There is bilateral subcostal retractions also which are present. So by chest indrawing, fast breathing, both of them are present, but there is no other danger sign. Whenever there is a febrile child or child having cough coming to you with fast breathing or chest indrawing, you say the diagnosis is pneumonia. According to IMNCI, if it is pneumonia, you have to start oral antibiotics
and review the child in 48 hours. There is no need for radiological evaluation. So the correct answer to this question is start oral amoxicillin without chest x-ray and review in 2 days. Let us do a brief review of IMNCI diagnosis of pneumonia. How do you do that? Now the IMNCI guidelines say that whenever a child age less than 5 years comes to you with fever or respiratory symptoms, first of all you check for fast breathing. What are the cutoffs that you use for? You check if the child's age is less than 2 months. The cutoff for respiratory rate for fast breathing for tachypnea is equal to or more than 60 per minute. For age 2 to 12 month, the cutoff becomes equal to or more than 50 per minute. And for 1 to 5 years, the cutoff is equal to or more than 40 per minute. This rule is applicable only till 5 years of age. Beyond 5 years of age, respiratory rate correlation with the likelihood of pneumonia is not significant. So first you check for fast breathing. Second, you check for chest indrawing, also called as chest retraction, whether the accessory muscles of respiration are being used or not. Please remember that nasal flaring is not a criteria for pneumonia according to IMNCI. I repeat, nasal flaring is not a criteria. It is a point which sometimes, despite us being residents, we make these mistakes. And third, we check for general danger signs. General danger signs include severe malnutrition, abnormal sleep or difficult to awake, that is lethargy, inability to feed or drink, and convulsions. And then you make the diagnosis. How do you make the diagnosis? This table will tell you how you make the diagnosis. Before I start writing in the table, you see the color coding which is used by IMNCI. Green code, the child goes back home. There is no danger sign, no need to follow up. Yellow code, the child needs to be followed up. And pink code, the child needs referral. If you are sitting in a PHC, if you are sitting in a tertiary care center and this child comes to you, you have to admit the child. These are the 3 color codes, green, yellow and pink. So the IMNCA guidelines say any child having no fast breathing, no chest indrawing, no danger sign, there is no pneumonia. And if there is no pneumonia in the child, what you will do? No antibiotics are needed. It is generally a self-limited, probably viral infection, and there is no need for giving any antibiotics, only supportive therapy, symptomatic therapy you can give. So you can give paracetamol. If there is some wheezing happening, you can give SOS bronchodilators, but there is no role of antibiotic. If there is fast breathing or chest indrawing or both, but no danger sign, you say the child is having pneumonia, and the code that you will be using is yellow code. And if you call it as pneumonia, what you shall be giving to the child? You will be starting the child on oral amoxicillin. Amoxicillin is the drug of choice. It will be given for 5 days. And any child started on amoxicillin, you have to review the child in 48 hours. That is, review the child in 2 days. No need to do investigation in the child. However, if the child is having any general danger sign, as you can see here, 4 danger signs I just told you, SpO2 below 90% on room air or stridor in a calm child, you will say the child is having severe pneumonia. And if there is severe pneumonia is also known as very severe disease. Please remember that there is no category as very severe pneumonia. Severe pneumonia is called as very severe disease. People often ask, sir, why 2 names? For certain questions, there are no clear answers and we have to accept them. There are reasons for that, of course, but unlikely somebody is going to ask you that. Some of the things we have to accept the way they are. So severe pneumonia, what do? You will start the patient on IV ampicillin along with gentamicin. However, if you are sitting in a PHC, you will give the first dose of IV antibiotic and you will refer the child to higher center. Refer to higher center. If you are already sitting in a higher center, tertiary care center, then you will not refer, you will admit the child. And make sure that you are referring the child always on oxygen. Make sure that there is oxygen cylinder available, it has oxygen, there is apparatus to give, and the person who is accompanying in the ambulance should be qualified and should be knowledgeable enough to administer oxygen to the child, because hypoxemia during transport can be devastating to the child, and it is duty of the medical officer or the consultant in charge to make sure when the referral is happening, these things are taken care. This is according to IMNCI, right? So IMNCI occasionally asked, it has not been asked in the year 2024, the last NEET SS exam, And it has not been asked in INI SS exam in the last year also. But in the subsequent previous exams, you will find this question to be asked. So that is why I did a quick, brief, important review. Let's move to the next question. This next question is very similar to NEET SS 2024. They are asking what is true regarding Lemire syndrome. I don't know why, but Lemire syndrome, somebody is obsessed with the topic. The question on Lemire syndrome was asked in NEET SS 2023. It was previously asked in NEET SS 2021 and it was asked in NEET SS 2024 also. It's a very small topic per se, and if you try to search in Nelson, you will hardly find a few mentions of Lemire syndrome in the chapters of ENT and in the chapter of infections. But this topic is important, so we will do a very brief review as well. So what exactly is Lemire syndrome? Let me tell you in simple language. Tonsillitis happens. By which organism? There is an organism known as Fusobacterium necrophorum. This is an anaerobic bacteria, and if adequate antibiotic coverage is not given, or there is some risk factor like low immunity, sometimes for no reason, in certain children what it will do is, it will form peritonsillar abscess. So tonsillitis, then peritonsillar abscess, and then it will encase and cause thrombophlebitis of the internal jugular vein. And internal jugular vein thrombosis due to infection is called as Lemire syndrome. So what is the description? Look at these four options. Internal jugular vein thrombosis after oropharyngeal infection. D is your correct answer. So what are the key points about Lemire syndrome you should know? It is categorized as infectious thrombophlebitis of the internal jugular vein. Development of IJV thrombosis occurs after a severe oropharyngeal infection like acute tonsillitis. And the sequence is important. This sequence has been asked in fellowship entrance exam. Tonsillitis, then peritonsillar abscess, then thrombophlebitis. And what is the most common cause? I just told you, this is Fusobacterium necrophorum. And this is a bacteria which is anaerobe. So it is an anaerobic bacteria. And what are the complications? It can cause vascular compromise. Occasionally, yes, but more commonly, it has a tendency to disseminate and cause septic shock in the child. So septic shock is a known complication of these patients. What is the investigation of choice? You need to do, obviously you will find ESR, CRP to be on the higher side, the leukocytosis will be there, neutrophilia will be there. Apart from that, these patients will have evidence of thrombophlebitis when you do ultrasound Doppler study. So ultrasound Doppler study in a patient with raised markers and clinical tonsillitis, you will suspect Lemire syndrome. It is diagnostic of Lemire syndrome. And Lemire syndrome, contrary to popular perception, it does not generally require surgery or surgical drainage. Broad spectrum antibiotics have a good coverage provided they are started on time and no shock has happened. So the treatment of choice in these patients will be starting a combination of IV beta lactams. You can use either penicillin G or you can go for ceftriaxone. It is combined with metronidazole. This combination given for about 7 to 10 days is the therapy of choice. Obviously, if complication happens, then you need to manage the complication also. I'm not trying to overdo the topic because again, questions which have been asked have been very simple in NEET SS. All they're asking is whether you have a knowledge about the topic or not. And all the questions asked on Lemire syndrome right now are there in the slide that you are seeing. Let's move further. Talk about question number 13. It's a simple one, it's an easy one, and very similar question was asked in NEET SS, INI SS in the last 5 years in different exams. So, a 2.5-year-old child presents with high-grade fever, barking cough and stridor. So, fever, barking cough, stridor, you already know where it is going. And X-ray neck is showing steeple sign. So, what is the likely diagnosis? Croup, also called as laryngotracheobronchitis. Stridor is not present at rest, stridor is present only on crying, which indicates it is not severe croup. If it is initial, not severe croup, initial presentation is there, the drug of choice for reducing airway edema is dexamethasone. And so in this patient, you will be giving oral dexamethasone. If the same child of croup develops stridor at rest, cyanosis, or progressive respiratory distress, which is not responding to dexamethasone, then you will go in for racemic epinephrine nebulization. But in this question, there are two parts. First, you make the diagnosis is croup. Then you look at the degree of stridor. If stridor is present only occasionally or on crying, intermittent stridor, The answer will be dexamethasone. If they say stridor is persistent, even at rest, and patient is not responding to dexamethasone, or they say patient has developed clinical cyanosis, then your answer will be racemic epinephrine nebulization. And this is how the steeple sign looks like. As you can see, there is a subglottic narrowing and airway becomes broad as it comes down. Question number 14. Which of the following? This question, if you have gone through the Nelson updates as well as the rapid revision of PrepLadder SS, you would have known this question already. I have discussed in details. So, which of the following is the FDA approved monoclonal antibody useful in RSV associated acute bronchiolitis? Traditionally, we have been using palivizumab, but now palivizumab is no longer used. It is nirsevimab, which is FDA approved for use. Less than 8-month child, they are useful for prevention of bronchiolitis, and 8 months above children, if particular risk factors are present, they are approved for use. I will summarize just a minute. What about C and D? Casirivimab and imdevimab are the monoclonal antibodies which are useful sometimes as combination therapy in COVID-19 pneumonia. So these are the antibodies which are useful in COVID-19 pneumonia. So what is the answer to this question? Nirsevimab. Let's do a quick review. How would you prevent acute bronchiolitis? We are not talking about treatment, we are talking about prevention. First of all, hand hygiene, according to Nelson, is the best measure when you are handling young children, because RSV sometimes gets transferred through the contaminated hands and fomites. Second, ribavirin has no role in prevention. It has no role in treatment also. Palivizumab is no longer recommended. What do you use? Approved drug right now for prevention in infants less than 8 months of age. If there is a seasonal outbreak, it is nirsevimab. So very costly agent, but it is used in United States and many European countries, and selected parts you can always import the drug in India also. Anti-RSV monoclonal antibody directed against F protein of RSV. Would you be using in older than 8 months of age also? Yes. It is approved for use in age 8 to 19 months if they have risk factors like chronic lung disease of prematurity, that is BPT, if there is immunosuppression like HIV or chronic steroid intake, and cystic fibrosis patients. So these points, if you have not gone through them, add them. I would advise Nelson updates of PrepLadder SS. If you are not going through, you are missing out something. They are very important. Last NEET SS also, a lot of students said last NEET SS was held in 2025 only. It was 2024, held in 2025. A lot of students said, sir, there was significant number of questions asked from Nelson update. So if you can read the entire Nelson, great, but if not, take the help. We are doing it for you. Moving further. Question number 15. Which of the following is the most common type of tracheoesophageal fistula in case of newborns? It's a simple one line, it's a simple thing. Tracheoesophageal fistula, there is a classification. Multiple classifications have been given. One of them is walked classification. In this, from type A to type E, 5 types of TEF are defined. And it depends upon whether it is isolated fistula or it is associated with esophageal atresia. And it's a one-liner thing that the most common variety, more than 90% in newborns, is type C TEF. Type C TEF is the TEF in which there is proximal esophageal atresia. Proximal esophageal atresia. Atresia means blind tube, along with distal tracheoesophageal fistula. Let me show the photograph, it will become clear to you. This is the photograph you are supposed to understand. There are 5 types of TEF. This type C TEF comprises about more than 90% of all TEF, and it is the most common variety. In these patients, the esophagus ends in a blind tube. The lower part of esophagus is attached to the trachea, forming a fistula. So you can see proximal atresia of esophagus along with distal fistula. This is the most common variety. And how do these newborns present? There will be antenatal history of polyhydramnios. Postnatally, the children will develop frothy secretions drooling from the mouth. If you try to pass a tube into the esophagus, it will not go, there will be resistance and it will get coiled, and when you do chest X-ray, coiling of the tube will be visible. The distress can be multifactorial. One of the reason is all these secretions which are drooling, child can aspirate, and urgent surgery is recommended in these patients. Then we have the other varieties. You have type A, type B, type C, type D, type E. Theoretical thing, you have already read about it. Type E is the variety which is also called as H type TEF. This is the variety which is only 5% but comes to attention beyond infancy. So the most late presentation if they ask, then it will be type E, which is H-type TEF. There is no atresia present in these patients. If you go from type A to type E, you find in type A, there is no fistula, and in type E, there is no atresia, right? So these are the subtypes you are supposed to know, at least give a reading of these 5 varieties. But most important is type C. Question number 16. A child presents with productive cough, dyspnea and chest pain. He gives history of expectoration of tan brown colored cast in sputum occasionally. On auscultation, breath sounds are reduced, likely diagnosis. Now what are we looking at? Coughing is happening, and the hallmark in these patients is brown colored cast coming in sputum. And thirdly, there is some obstruction to the airflow causing reduced breath sounds. If you have gone through this topic, I have discussed in details. It's a very important topic. It's a Nelson update. This question is being asked multiple times in super specialty exam, both INISS and NEET SS. It is plastic bronchitis. Wherever you find this word, respiratory symptom, reduced breath sound, and brown colored cast coming into sputum, these are the keywords, the buzzwords, which will tell you the diagnosis in the patient is plastic bronchitis. And plastic bronchitis, let us do a quick review. This is what happens in plastic bronchitis. These casts are forming in the tracheobronchial tree. They are causing respiratory symptom, they are causing dyspnea, they are interfering with gas exchange, and they are causing obstruction symptoms. Many times plastic bronchitis can be caused by viral infections like adenovirus, post-influenza, influenza A can cause it. But many times it occurs as a complication of cardiac surgeries also. Like there is a surgery known as Fontan operation. Its complication is plastic bronchitis. It's multifactorial. And rarely it can occur as a part of lymphatic abnormalities also. Detailed review already done. Plastic bronchitis, when will you clinically suspect? Coughing, dyspnea, wheezing, pleuritic chest pain, hypoxemia. Patient expectorates. This is the most important thing. This is the most important thing. Tan colored casts with rubbery consistency in the sputum will be coming out, fragments will come out, auscultation will reveal reduced breath sounds. And some patients show bru de drapeau, sound similar to a flag flapping in the wind, right? If there is a strong wind blowing and there is a flag, that flag hits against the mast and there is a particular sound which is produced, tuck, 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 that kind of a sound. That is called as bru de drapeau, which will be heard on auscultation. And treatment in the patient, a rigid or flexible bronchoscopy to remove the cast. If there is a treatable cause underlying, you will treat that. Adjunct therapy is for fibrin cast, you will use nebulized TPA to dissolve them. For mucus or mucin-based cast, you will use NAC or DNSB. This will be useful if you do the analysis of the expectorated cast fragments. And if there is a surgical procedure, if there is a lymphatic abnormality, you will plan surgery for the underlying lymphatic problem. Question number 17. Which of the following is not a diagnostic criteria for asthma as per latest GINA guideline? Again, GINA update, it is there in details. The latest GINA guidelines are there on the super specialty app. If you have not gone through that, please go through it. If you're not a subscriber, please subscribe and go through it. But again, even if you're not a subscriber, just try to understand that GINA guidelines are updated very frequently and there are subtle changes which keep on happening. In GINA 24 as well as GINA 25, there has been a significant change that FEV1 by FVC, it is no longer considered a criteria. Is it reduced? Yes. But is it a criteria? No. So what is the answer which is not a diagnostic criteria among the options given? FEV1 by FVC reduction. And what about the diagnostic criteria summary, GINA 2024? In children 6 to 11 years, adolescents and adults, both should be present. What are both? There should be reversible, waxing and waning kind of variable symptoms of obstruction. Symptoms should be there. And second, spirometric evidence should be there of obstruction. Both of them should be present, and this should be airflow limitation which should be documented. So have a look at the criteria. History of typical variable respiratory symptom. What are the symptoms? Wheezing, shortness of breath, chest tightness, cough. They should be variable. They should be variable in time, variable in intensity, worse at night or awakening, and they can be triggered by allergens, viral infection, cold air, exercise, and laughter, etc. And second, there should be history of, there should be confirmed on spirometry, there should be confirmed expiratory airflow limitation. I hope you know that asthma affects the expiratory components more compared to inspiratory. So there will be a positive bronchodilator responsiveness test, excessive variability in PEFR, increase in lung function after 4 weeks of therapy with steroids, positive bronchial challenge test, and excess variation in lung function between the visits. There is no FEV1 by FAC, and so the odd one out, the answer is that. Moving to question number 18. A child with recurrent pneumonia and malabsorption underwent sweat chloride testing which came positive, which means could be cystic fibrosis. His CFTR gene mutation was positive for phenylalanine 508 deletion, delta F508, the common variety, the common mutation. Which type of mutation it is? So they are basically checking whether you have read the table of Nelson or not. Similar table is there in medicine textbooks of Harrison also. And this table, don't try to overread. I have discussed in my classes also, in my recorded lectures also. Let's have a look at the table and then we come back. There are 6 classes of cystic fibrosis mutations. There are class 1 to class 6. Class 1 is the most severe. Class 6 is the most mild. As you move from class 1 to class 6, severity reduces. Class 1, you see here, look at this particular area. Look at this particular area. In class 1 mutation, no functional CFTR protein is getting formed. Most severe form. CFTR class 2 variety, there is CFTR trafficking defect. Trafficking means the protein which is formed, it is misfolded, and after translation, it cannot cross the cytoplasm and reach the surface of this epithelial cell. It gets destroyed within the cell itself. This is called as CFTR trafficking defect. And the example for this is phenylalanine 508 deletion. In other words, the common variety delta F508 is class 2 defect. And what is class 2 defect? CFTR trafficking defect. Class 3, there will be defective channel regulation. The opening of the channel will be compromised. So remember the keyword defective channel regulation. The typical example for this is glycine 551 aspartate. This in common language is also known as delta F508. In common language, this variety is also called as G551D. It is also a relatively common mutation. Examiner can ask you question on this or they can ask you question on this. Delta F508 is class 2, G551D is class 3. Delta F508 is CFTR trafficking defect, G551D is defective channel regulation. And then we have the other forms like class 4 is decreased channel conductance, the reduced synthesis of CFTR and decreased CFTR stability. So these examples and the names you should remember. Even if you cannot remember every single mutation, it is not needed also. So what is the answer? What is the answer to this question? CFTR trafficking defect is your answer. Moving to question number 19. It is similar to NEET SS 2024. A child has been diagnosed with hypertrophic cardiomyopathy. All of the following should be avoided in this child except we have discussed it's a simple thing. In hypertrophic cardiomyopathy, there is left ventricle outflow tract obstruction. Any drug which is worsening the left ventricle outflow tract obstruction, that should be avoided. So digoxin should be avoided, diuretics should be avoided, nitrates should be avoided. But beta blockers can be used. In fact, beta blockers are considered the drug of choice for medical therapy in such patients. Let's do a quick review. At CM, there is systolic anterior motion of the mitral valve leaflet. There is diastolic dysfunction, but there is LV outflow tract obstruction. So what are the things that you will do? As a part of medical therapy, you will avoid strenuous exercise that can worsen the patient. Second, you will avoid the drugs which worsen LVOT obstruction. What are these drugs? You will avoid nitrates, you will avoid digoxin, and you will avoid diuretics. Also, in these patients, you will use drugs which can improve the left ventricle outflow tract obstruction. The drug of choice will be beta blockers like propranolol. Second line drug or alternative drug is verapamil, which is a type of calcium channel blocker. And if they ask you what is the surgical procedure which you can perform, there is a surgical procedure known as Morrow's. M-O. O is important. Morrow's. O is correct. Morrow's myectomy procedure. Details of this procedure I have already discussed in the detailed video. So this is the therapy, and if you go through the past papers of NEET SS and NISS, this particular thing has been asked 3 times, right? So please go through it. This is the bare minimum you are supposed to remember. Next, question number 20, similar to NEET SS 2024 question. Which among the following is true regarding oxygen flow rate and oxygen concentration provided by a Venturi mask? Now, it's a fact-based question. In a Venturi mask, when you are using, the FiO2 should be about 30 to 50% and the flow rate is 5 to 10 liter per minute. If you look at the option, no option is perfect, but the closest option is B, flow 5 to 10 liter per minute, FiO2 40 to 70%. Look at this part. Nelson says Venturi mask, the FiO2 adapters provide FiO2 of 0.3 to 0.5, that is 30 to 50%, and the flow rate is 5 to 10 liter per minute to achieve the desired FiO2 and avoid rebreathing. This is regarding the Venturi mask, and then they have given other values for other types of methods as well. If you want to push yourself and push the boundary, many times I get messages from students on Instagram, residents, sir, I cannot read entire Nelson, but what are the things, what are the areas you feel I should read thoroughly in Nelson, which will actually help me in the exam? Let me tell you a hidden fact. Chapter number 86 of Nelson 22nd edition. Go through it. Mug it up. There are a lot of facts and formulas and other things given. It's a tough chapter to read, but if you just go through it, you will find that one of the favorite chapters of super specialty examiner, both NEET SS and INI SS, it is this chapter. Something out of it definitely gets asked. I have covered a lot of segments of this in my videos, but as a chapter, as a student, end of the day, no coaching material or no platform can ever replace reading the standard textbook. I keep saying that. Bedside learning cannot be replaced. Textbook reading cannot and should not be replaced. So if you have time, I repeat, go through chapter number 86. It's not a magic wand, but at least it will make sure that these kind of questions, it has all the values, Venturi mass se kitna SpO2, kitna FiO2, what is the flow rate in this, then it has various types of, formulas, calculation formulas for the flow rates. So please go through that. Let's move to question number 21. Similar, in fact, it is the same as NEET SS 2024 MCQ. It's a PYQ. Which of the following is true regarding VSD? 4 options. Let's go one by one. Muscular VSD does not close spontaneously. Wrong. Muscular VSD is the one which closes spontaneously. Small VSD have severe symptom with less loud murmur. Wrong. Small VSD have loud murmur but no symptoms. Because the jet of blood is passing through a narrow area, so the turbulence will be very high. But because the shunt size is less, so the symptoms or overloading symptoms of CCF will not be there. Small VSD always needs surgical closure. Wrong. If you look at different textbooks, Parks, Nelson and Indian textbooks, they all agree about ranging from what source you are quoting, 50 to 70, sometimes up to 80% of all small VSDs close, because most of these are actually muscular VSDs. They close spontaneously. Large VSDs can have left ventricle hypertrophy. That is correct. Large VSDs can have biventricular hypertrophy also. There can be right ventricle hypertrophy, there will be left atrium, left ventricle enlargement. So large VSDs often have biventricular hypertrophy. This is mentioned in Nelson also. Nelson clearly says that in large VSD, the chest X-ray shows gross cardiomegaly with prominence of both ventricles, left atrium and the pulmonary artery. And ECG shows biventricular hypertrophy. The P waves may be notched, indicative of left atrial enlargement. This particular point of LA enlargement on ECG is another MCQ. That is why I have put this photograph over here, right? So just add it to the notes. Question number 22. Which of the following is the most commonly used echocardiographic parameter to define hemodynamically significant PDA in a unit? This is previous INI super specialty MCQ. And it is based upon AIMS protocol. It's a one-liner I have discussed in my rapid revision also and update also. The most commonly used parameter is looking at the ratio between left atrial size and the aortic size. So we call it as LA by AO ratio. If it is more than 1.5, that indicates hemodynamically significant PTA. So what does the protocol say? What are the one-liners you should know? According to protocol, most commonly used echo parameter to define hemodynamically significant PDA is LA by AO ratio. It has 79% sensitivity and 95% specificity after 24 hours. But the most specific echo parameter, most common is different, specific is different. There are 2 specific parameters. First, diastolic reversal at the descending aorta, and second, increased LPA diastolic velocity. And how do you define HSPDA? There is a criteria given in Nelson. It says on echo, if you find PDA size equal to more than 1.5 mm, if there is unrestricted pulsatile transductal flow, there is LA by AO ratio equal to or more than 1.5, and absent end diastolic flow in descending aorta, hemodynamically significant. Additionally, AIMS protocol talks about some clinical suspicion features also. It says if there are bounding pulses, wide pulse pressure more than 25, hyperactive precordium, systolic murmur or tachycardia, then also it is HSPDA. All the students preparing for your university exams, listening to this discussion, all the students preparing for NEET SS, even department assessment, this is a star topic. Please try to go through the role of biomarkers also. I am not discussing here, but it has been covered in my update on the new updates segment of PrepLadder SS. Defining HSPDA is very, very important, right? ये examiner पूछता है. They are very fond. All the senior examiners, they are very fond of it. I am telling you. If it gets asked and you answer it correctly, do let me know. Question 23, similar to NEET SS 2023, it's a previous year question. What is the therapy of choice for infective endocarditis caused by Coxiella burnetii? Coxiella burnetii causes Q fever, and generally it is a self-limited infection. Sometimes it can cause infective endocarditis. If it is non-infective endocarditis, then doxycycline alone is sufficient. But if it is infective endocarditis, then you need to add hydroxychloroquine in such patients. So B is your correct answer. It's a fact-based, guideline-based therapy. It's mentioned in Nelson also that early therapy, initial Q fever, you give doxycycline alone. But for persistent focal Q fever, especially endocarditis and mostly in adults, therapy for 18 to 36 months is recommended. And you will use, for endocarditis, you will use doxycycline and hydroxychloroquine for 18 months or longer. Question number 24. Functional closure of ductus arteriosus is completed by, it's a direct line taken from Nelson, it is completed within 10 to 15 hours of birth. So, this is what the Nelson and other standard textbooks say. I have summarized at one place so that you can remember and mug it up. These are reliable values. These are not chat GPT values. These are all values mentioned in Nelson, your Parks and other standard review material. They all agree. There are minor variations. I have tried to find the middle common ground. Ductus venosus closure, functional closure is, due to spasm of the vessel. But anatomical closure will be permanent closure due to fibrosis of the lumen. So, functional closure of ductus venosus occurs within minutes to hours, generally within 6 hours. Anatomical closure occurs by day 7 of life. Foramen ovale closes anywhere between birth to 3 months. Anatomical closure is variable. And many times it can be open up to 3-4 months also, but it will not be significant if there is no shunt happening, even if there is a delayed closure. Remember, patent foramen ovale per se is not significant in many patients. And ductus arteriosus, within few hours, functional closure happens, completed by what? 10 to 15 hours. Anatomical closure occurs between day 10 to day 21, okay, at these points. Question 25. A neonate developed cyanosis in the first week. He was started on therapies, was not responding. When alprostadil was started, cyanosis improved dramatically. All of the following condition can produce such a clinical picture. Whenever a newborn in the first or 2 weeks of life comes, I am saying first 2 weeks because many times there can be some preterm children also. There is cyanosis or shock and patient improves on giving alprostadil, that is prostaglandin E1, you should suspect the patient is suffering from ductus-dependent congenital heart disease. Ductus-dependent congenital heart diseases are of multiple types. You have ductus-dependent pulmonary circulation and ductus-dependent systemic circulation. If you look at these 4 options, all the 4 options, they are ductus-dependent lesion. But what is the correct answer? The correct answer is A, hypoplastic left heart syndrome. Why? Because all these 3 conditions are ductus dependent pulmonary circulation. Their cyanosis improves on with PGE1, that is prostaglandin. Hypoplastic left heart syndrome does not present with cyanosis, it presents with shock, and shock improves with PGE1. So, which cannot be the diagnosis in such a child? Hypoplastic left heart syndrome cannot be the diagnosis. To make it more clear, 2 types of lesion, ductus dependent pulmonary lesion, ductus dependent systemic lesion. All the pulmonary circulatory lesion present with cyanosis. All the ductus dependent systemic circulatory lesion, they present with shock. If cyanosis improves with alprostadil, you will consider this column, the first column. If shock improves with prostaglandin, you will consider this column. Right? It's a small thing, add to your notes. And regarding alprostadil and its use, the apnea can happen, fever can happen, and intubation apparatus needs to be ready. Remember that prostaglandin infusion is always a temporary measure. It is never the definite measure. Definite measure will always be surgery in such patients. Details again, detailed video there is. Question 26. A child with large VSD was lost to follow-up, now presents with resolution of CCF symptoms, central cyanosis and digital clubbing. What is the likely diagnosis? Large VSD means large left to right shunt. Lost to follow-up, coming with cyanosis means the shunt has reversed. And reversal of shunt is Eisenmenger syndrome. It's not a good thing to have Eisenmenger syndrome. There are drugs to decrease pulmonary pressure, but eventually mortality is very high and most surgical procedures fail. Books say that heart-lung transplant can be done, but practically speaking, how many heart-lung transplant you see, that also in young children, right? So it's like a death sentence. So remember the funda, any left to right shunt lesion, lost to follow-up, comes to you with cyanosis and clubbing and some degree of dyspnea, but CCF symptoms are not prominent. You will think of Eisenmenger syndrome in the patient. It's a pulmonary vascular obstructive disease. Permanent changes occur due to pulmonary hypertension. That is called as Eisenmenger syndrome. Question number 27. It's a fact-based one-liner. Old NEET SS question I have used here as well. Old means pre-COVID. MCQ is an MCQ. Just like a currency note is a currency note, provided demonetization has not happened. So a child with cyanotic disease found to have SVT, supraventricular tachycardia. Evaluation revealed Wolff-Parkinson-White syndrome. What disease it might have been? The most common congenital heart disease associated with Wolff-Parkinson-White syndrome is Epstein's anomaly, and that is your answer. It's a fact-based thing. Nelson also says ECG shows right bundle branch block, and there is a chances of Wolff-Parkinson-White syndrome, which can lead to episodes of supraventricular tachycardia in such patients. Epstein's anomaly, 2 or 3 things about Epstein's anomaly frequently asked. First of all, box-shaped heart or balloon-shaped heart, number 1, massive cardiomegaly. Number 2, WPW syndrome, risk of SVT. Number 3, pregnant lady taking lithium. Number 4, it's a ductus-dependent congenital heart disease. Right, these 3 or 4 points, good to remember. Question 28. Child is diagnosed with acute rheumatic fever. He also has migratory polyarthritis. Which among the following shall be the preferred drug in the treatment? They're saying treatment. Some of you would have marked in the exam on app as benzathine penicillin G. No, benzathine penicillin G is used for prophylaxis. For treatment, you will use prednisolone and aspirin. So aspirin is the one which is given in treatment because there is arthritis, and so B is your answer. If you have to do the treatment of rheumatic fever, remember, if there is carditis present, you prefer steroids like prednisolone. And if it is arthritis without carditis, you prefer high dose aspirin in the patient. The total duration of therapy is roughly about 12 weeks. Prophylaxis, you prefer giving antibiotics, and it is secondary prophylaxis generally which is used in these patients. So, go through the notes, don't make silly mistakes. And for those who are listening to this discussion, these tests are there on the app. The optimum way to listen to this discussion is, many of you I know, you directly jump to the discussion part only. It's okay, but solving question, then listening to the discussion, and then adding points to your notes. This will make sure that you never forget these points, because once you have made a mistake, then you will remember it forever. All the mistakes I have made in my personal life, professional life, and I keep on making. I keep on remembering also. The same is true for you also. And at the same time, you're not supposed to make all the mistakes in the exam. Do it now during practice, right? So if you're running short on time, listen to the audio part, the video part, explanation part, but try to solve the paper also, try to solve the questions also on the app, because it's a very useful exercise. End of the day, you are going to solve the question, not write a theory paper in the exam. Question number 29. Similar to NEET SS 23, a child is having short stature, dysplastic nails, ASD and digital abnormality. Can you see this child is having this digital abnormality? This is what you call as post-axial polydactyly. The patient is having post-axial polydactyly. Hrithik Roshan has pre-axial. This child has post-axial. So what are the clues? Short stature, dysplastic nails, atrial septal defect, post-axial polydactyly. What are we thinking of? All fitting into Ellis-Van-Crevald syndrome. In Ellis-Van-Crevald syndrome, single atrium is more common, but many patients can develop ASD also, which is the second most common heart disease. Why it is not Holt-Oram syndrome? Holt-Oram syndrome can have ASD. It can have limb defects, but it will be either limb hypoplasia or absent thumb. Short stature is not commonly seen and dysplastic nails is never seen in Holt-Oram syndrome. So closest differential is Holt-Oram, but that is not the answer. Fanconi anemia, hand-foot genital syndrome, both of them again, thumb abnormalities are there. They will generally not have significant short stature or dysplastic nails. So how do you differentiate? Go through this table, add this table to your notes. Ellis-Van-Creveld versus Holt-Oram syndrome. Ellis-Van-Creveld syndrome, mutations in the EVC gene on chromosome 4p. Holt-Oram syndrome, TBX5 gene on long arm of chromosome 12. Ellis-Van-Creveld, polydactyly and nail problems like dysplastic nails. ASD and VSD can be present. Here, defects of the upper limbs are there. Short or unequal arm bones leading to limb hypoplasia will be there. Here, short stature is there, but there is no short stature mentioned in Holt-Oram syndrome. Right. Question number 30. Cardiac looping. As I said before, cardiac looping, small video, summary video. It will be separately posted in the coming days in the super specialty app only for subscribers. But if you have time, please go through cardiac looping. Cardiac looping was asked in NEET SS and there were two questions, one direct, one indirect related to it. This is one of that direct question. The problematic question is this. So identify the true statement regarding cardiac looping during embryogenesis. Let's try to understand what is happening here. Cardiac looping kya hai? Cardiac looping is a process which occurs quite early in life. Now, the normal tendency of the body is to produce symmetry. My right hand and left hand should be symmetric. My right limb and left limb should be symmetric. My right testis and left testis should be symmetric. My right lung and left lung should be symmetric. Of course, there will be minor differences in the lobes and the patches and other things. The left lung has to make space for the heart. But apart from that, symmetry is what body demands. But there are certain organs where symmetry is not good. One of that organ is heart. Heart has to be asymmetric. Right side has to be different from the left side. And what produces this asymmetry? This is produced by cardiac looping. Cardiac looping occurs somewhere in the 4th week of intrauterine life between day 22nd to day 24. Cardiac looping involves the twisting and movement of the primitive cardiac tube so that the orientation of chambers is changed and right side of heart differs from the left side of heart. We'll come back to these options. Let us first understand what is happening in cardiac looping. I'm giving you a very brief summary related to the topic. The actual topic is much bigger. So cardiac looping, what does Nelson say? It is responsible for asymmetry between left and right side of heart. Sometimes you just try to remember कि cardiac looping क्या होता है, right? Understand in a simplistic way. It is the process, nature's way of ensuring left and right side of heart are different. In cardiac looping, when does it begin? 20 to 24 days, that is 4th week of gestation. Now what happens in this is foregut, this is the primitive heart tube which is forming cardiac tube. It has a right part and it has left part. What will happen is the right part will migrate ventrally. It will bend ventrally. This is the beginning of cardiac loop. Then there are other segments of cardiac looping also which happen. There is a S-shaped, L-shaped which is produced. There is a S-shaped which is produced and so on. Details again, they are not needed right now. But this key point to remember, the right side of tube moves ventrally. This is the most important thing. Right side of tube moves ventrally. And there is asymmetric signaling. There are genes known as SHH gene and nodal gene which produce asymmetric signaling. Different signaling on right side, different on the left side. And they are the ones responsible for producing different morphology on the two sides of heart. And looping makes sure that left ventricle aligns with sinus venosus and right ventricle aligns with truncus arteriosus. Sinus venosus is the one which is going to form left atrium and right atrium. And right ventricle is the one which is going to form, truncus arteriosus is the one which is going to form pulmonary artery and aorta. And that is why when abnormalities happen, left ventricle is sometimes associated with common inlet left ventricle and double outlet RV is a condition which is produced when there are abnormalities in this. So remember the funda, LV aligns with sinus venosus, RV aligns with truncus arteriosus. These are the basics of cardiac looping. So look at the question now. Cardiac looping begins after 5 weeks, wrong. Left-sided primitive heart tube bends dorsally, wrong. Right-sided heart tube bends and that also ventrally. Asymmetric signaling by SHH gene is involved, correct. Left ventricle aligns below truncus arteriosus is wrong. It aligns below sinus venosus. So what is the correct answer? C is your correct answer. At least now this question gets asked or some points get asked. You will not go wrong. But cardiac looping is a tough topic. And cardiac looping, the questions, if you look at the options, that seem to have been framed directly from Nelson. So brief summary of that, some additional points and some more points. There is a separate video. It will be made available to you shortly in the coming days. So go through it before you sit in the December NEET SS exam. Thank you so much and keep learning.